Hello, everyone. My name is Eddie Salinas. I am the Communications Coordinator for the Implementation Science Coordination Initiative, or ISCI, at Northwestern. Welcome to the Adapting Guideline Implementation to Local Environments, or AGILE tool webinar. This tool builds on established frameworks from implementation science to enable users to select relevant barriers from a menu and receive a ranked list of recommended strategies. This presentation is being brought to you by Dr. Edmond Ramly, who is an assistant professor at the University of Wisconsin-Madison in the Departments of Medicine, Family Medicine, and Community Health and Industrial and Systems Engineering. Dr. Ramly's research aims to equitably improve the care of patients with or at risk for chronic conditions by closing gaps between evidence and practice. Drawing from implementation science and human-centered design, Dr. Ramly designs, implements, and evaluates interventions that are both locally adapted and practically scalable. Some examples of this include today's tool, the Agile tool, a decision support tool, the BP Connect and Quit Connect staff protocols for heart disease prevention, and the WCC EAL system for large-scale data-driven quality improvement. So without further ado, Dr. Ramly, go ahead and take it.
Thank you very much, Eddie. I just shared my screen. Does it look good? Okay, great. So thank you very much for ISCI for inviting me. I am thrilled to be here today and talk to you about Agile. So this is a decision support tool intending to provide a usable online interface to help teams of implementers or researchers or collaborations between them to take a specific intervention that is being implemented in a specific site or a number of sites and figure out what it's going to take to adapt that implementation to address the unique barriers and combinations of barriers in a given site with the combination of strategies that are best suited to address those barriers, based on what we currently know. And the way we've developed the platform is that it will grow as the science grows. So like Eddie said, I am at the University of Wisconsin-Madison, and I've worked with the ISCI team at Northwestern to bring in some of the systematic review data that they've developed around implementation of prep and barriers to that kind of implementation and putting them into the Agile platform. So today I'm going to go over the Agile platform overall, starting with the big picture of why that matters, what exactly it's doing, and then giving a live tutorial walkthrough of the Agile platform overall. And then I'll go over a specific example from prep implementation and go over a tutorial walkthrough of that. And then toward the end, I'll also walk you through how to register for a login for the Agile platform. So right now, anyone who is involved with an EHE project has access to Agile on as a beta user. And I'm going to go ahead and put that link right now in the chat. Many of you already have seen this in a variety of communications, including the communication that went out for this webinar. And I'll put it here in the chat as well. This is a shortened version of the link. You'll be able to go in and get the instructions for registration. I'll also walk through that as part of this tutorial webinar toward the end as well. So we do have a small group. As people trickle in, please feel free to ask questions in the chat, or even use the raise hand function in Zoom if you'd like to ask a question directly or make a comment, and we'll have a conversation. So I'm going to go ahead and get started with giving you the big picture, and then we'll dive into some of the tutorial and walkthrough pieces. At any point in time, feel free to jump in with questions or comments. So I want to make sure that I can control this. Okay, great. So the big picture is, as many of you know, being involved in implementing interventions in a variety of settings, we often need to balance standardization or fidelity to a planned intervention protocol or planned implementation strategies with the local needs of different sites and their contextual determinants to a successful implementation. That could include negative determinants, so barriers, or positive determinants, facilitators. Right now, a lot of the state of implementation science has focused on those negative determinants when we think about what strategies can be matched to them to overcome those negative determinants, those barriers. And so that's what I'll talk mostly about, but I'm happy to have some conversation at the end if anyone is interested about facilitators as well. So this idea of balancing, on the one hand, standardization or fidelity, on the other hand, the local contextual needs, including barriers of different sites. It's not necessarily an either or, right? So fidelity only or standardization only would be a one-size-fits-all, where we're going to determine an implementation blueprint, a set of specific intervention components, and say all sites are going to get the same thing. That would be one extreme. And another extreme would be to say every site's going to do whatever they want, to each their own. And in fact, they're not necessarily going to get any support in figuring out what they need and how to make it happen. Those two extremes are in fact unfair and inequitable, because they leave behind those sites that do need to figure out specific barriers and specific strategies to address those barriers, and sites that might not have the additional resources and support to do that kind of intense tailoring on their own. And of course, the one-size-fits-all would leave behind all kinds of sites that just don't fit with the mold. And oftentimes that mold, that formal blueprint comes out of large, well-resourced academic medical centers that are typically in urban areas where a lot of the clinical trials and implementation trials come out. So a one-size-fits-all is also going to be unfair and not equitable. So we need a third solution, essentially. And in engineering, which is part of my background, we in fact do provide a variety of ways to customize products and processes to the unique needs of different users and customers. If you were to buy a computer or buy a car, you might go on the vendor's website and get a set of menus of options, and you might say, I want this kind of processor and this kind of amount of memory, this kind of amount of storage, I want this size of screen, and so on. And you end up getting a fairly customized, fairly tailored product that meets the combinations of needs that you've specified without needing to have a personal computer engineer, right, following you around and designing a custom-made computer just for you. So we've balanced that out through this idea of configurable solutions. So we have menus of options, and essentially what we're doing is we're letting you as a user finish the design. So we're saying we've designed the thing, and we've designed certain components, certain characteristics of the thing to be configurable, to have different options, and then the users can choose among them. And because of the combinations of options available, you end up getting a pretty wide variety of different configurations. So it's a beautiful middle ground between one size fits all and to each their own. And why does it matter? Why do we need to be thinking about this? Why shouldn't we just say, look, yes, the one size fits all doesn't work, but if we spent enough time, maybe we would find a one size fits all that does work. And universal design, we do a variety of randomized control trials that bring in different populations, and we make sure that we come up with something that is going to work for everyone. it turns out that oftentimes adaptation at a local level can, or the lack of adaptation can lead to lower impact because the effectiveness that's been determined for a certain set of characteristics of a population or of a setting might not hold. You might actually have a drop in effectiveness, a drop in the population impact, or a drop in reach, or other components that produce impact, or you might simply not have enough adoption. There might not be enough uptake of the intervention, the thing that is being implemented. Or even if there is, there might not be sustainment. Within a given research study, people are going to use it because you're there. You might be providing some resources and support. Maybe a member of your team is actually helping them do this. Once you're gone, because it didn't fit within their context, within their workflows, within their needs, they stop doing it. And all of that leads, again, to increasing the health equity gap. Because like I said, the sites that are more likely to have these kinds of unique barriers that are not well addressed, that require a unique combination of strategies, might be left behind. And so we get practice disparities that also translate into health disparities. So we know that tailoring these implementation strategies to fit these local needs can help with whether it's clinics or any kinds of sites, right? Schools or hospitals or community settings adopt and sustain change that fits within their settings. But a lot of the current approaches to tailoring are very time-consuming and very expensive. So they require some form of external facilitation, whether it's practice facilitation, whether it's bringing in experts to help with conjoint analysis or group model building or concept mapping or implementation mapping. For the most part, those approaches still require a lot of expert support externally, and that can be very expensive, both in terms of the time and resources to bring in those experts, but also burdensome on the sites themselves. For example, in primary care, where I do some heart disease prevention implementation work, there's a series of national studies from the Agency for Healthcare Research and Quality called Evidence Now that showed that external practice facilitation actually does improve implementation of heart disease prevention guidelines. But it also showed that primary care clinics have a lot of difficulty in making the time available among their staff and among their clinicians for those external practice facilitators. And that limits the broader applicability of this kind of approach. So we need to complement these kinds of external supports. A lot of sites will need some kind of external support, but we can complement it with decision support tools, where the sites themselves can use the decision support tool, perhaps in preparation of working with an external facilitator, or during a collaboration with an external facilitator, or maybe after or in between sessions with a facilitator. The facilitators themselves can use it to prep for sessions, to engage a local site in brainstorming barriers and addressing, identifying strategies to address them, or to keep the ball rolling where, okay, last time you said we had these barriers, let's look at where we are now, which of them have we addressed, which different strategies might you want to try for the next cycle. So with a decision support tool, we can reduce that time and cost required for tailoring by giving these kinds of menus of barriers linked to matching strategies that local sites and the external people and organizations that support them, whether it's professional implementers or implementation research, study team members, or a combination to work together. And so we've developed that tool, the Agile tool, to essentially start with a list of known barriers and provide a ranked list of strategies based on the barriers that a user has selected. So essentially what we're doing is, it's a very simple process. You're going to select barriers, you're going to get suggestions for strategies, and then you're going to choose the strategies that will probably work for you. And it's not going to tell you, here is the final answer. It's going to give you a starting point, and then you can iterate. You can go through as many cycles as necessary. You can even pick a set of strategies. Okay, these ones are not going to work here, so we're going to skip them. These will, and then give it a try, and then a week later, a month later, 2 months later, come back and say, okay, what happened? What can we do differently? So it turns out, as many of you might know, probably know, there are known compilations of known barriers and known strategies in the field of implementation science. There are several. Right now, Agile focuses on a couple that are really well established, and I'll talk about those. There are others that we're planning to put in play as well. And if there are any specific that you use that are not CIFR and ERIC, you can put it in the chat. You can reach out to us and let us know. So the Consolidated Framework for Implementation Research, CIFR, right now in its first iteration, the developers, Laura Domschroeder and her colleagues, are working on the CIFR 2.0, one that, once that comes out, we'll be putting that in Agile as well. And so essentially, we take this published compilation of barriers and put them in as a menu of options that a user can select from. And then there are known strategies. So one of the better established ones is called ERIC, the Expert Recommendations for Implementing Change framework, and it's a list of 73 strategies. And CIFR in its first iteration is 39 constructs. And so there's been a mapping study that was published in 2019 by Waltz and colleagues that mapped CIFR and ERIC to each other. And this is right now the backbone of the Agile platform. There actually is an Excel spreadsheet that these authors have put out on cifrguide.org that you can use as well. What we've done is we've taken that and we've put some user-centered design processes around making an online interface that makes that usable, and adding some ranking algorithms to help the user guide what kind of ordering of the strategies they would like to see. And we've built the platform to be able to expand and grow with the field. Once there's CIFR 2.0, maybe there will be a mapping of that to ERIC. We'll put that as well. The Theoretical Domains Framework is another framework of determinants of successful implementation. And there is an existing mapping of that to the Behavior Change Techniques taxonomy. We have plans to put that in place. There's other frameworks for barriers, such as R equals MC squared, readiness equals motivation times capacity, and corresponding strategies, and we're working with those developers to put that in place as well. The other thing is, in addition to academic frameworks, the platform is set up in such a way that frameworks, that barriers and strategies that you identify from systematic reviews, as ISCI has done, or from your work with stakeholders, from focus groups, from surveys, from interviews, from actual implementation work and barriers that come up from that implementation, from co-design and participatory approaches. All of that could be lists that populate the Agile platform, whether it's a list of barriers or a list of strategies. And they could even be examples to add some detail to the existing academic platforms. I'll show you what I mean when we go to the tool itself. I'd like to pause on this slide and see if there are any questions or comments at this point about kind of the big picture, how things fit together and what we're trying to do here before we go and dive into the tool itself. Feel free to either put questions in the chat or unmute yourself and share your question or comment.
Hi, Edwin, just very quickly, when you click on the Agile login and once you walk us through the tool, is there an easier way to access the CIFAR guide or even some of these other concepts without having to go back and forth?
We can certainly put that into that page from the.
Okay.
Okay, sure. Yeah.
Okay.
Great question. Anything else? Okay. Here, I'll put a note of that. Okay, great. So I'm gonna go ahead and bring my browser in here. Sorry. Okay, great. So we want to do a walkthrough here. So I'm bringing in my browser to show you the overall what that looks like. So this is what the website looks like: adapting guideline implementation to local environments. Again, like I said, supporting the implementation of interventions into different barriers to implementation are relevant to your specific setting and recommending strategies more likely to overcome those barriers. Don't pay attention to this part right now. I'll get to it in the next demo. Right now, I wanted to show you the general version of Agile. So taking, if we select as our barriers framework CIFAR in its original version from 2009 and our strategies framework as ERIC from 2015, and then the 2019 CIFAR to ERIC mapping. No specific application right now. I'll show you a prep implementation application in a moment. We have these 5 different domains from CIFAR that organize the different barriers. And so we're going to select barriers from the list and then click on Find Strategies to see the list of strategies that match the selected barriers. So for example, among intervention characteristics, we've got different kinds of barriers that are related to, for example, the intervention source is the perception about whether the intervention is externally or internally developed, the trialability, to what extent are we able to try it and reverse course, and so on. So all of these are from CIFAR. And then we can select the ones that we feel are relevant for a given setting. Either prospectively, we anticipate this is going to be problematic for implementing a given intervention in a given setting, or retrospectively, we've done this and we found, you know, this was particularly problematic, and now we want to do we want to see what kind of course correction or strategies to address it we can put in place. So we're going to select a number of these. And in any of these domains, we can select as many or as few as is relevant. And we've worked with people who have chosen to say, of these 39, I'm going to focus on these 5 that are really particularly relevant, and others that have said, okay, these 15 or these 20 seem relevant. So you can go with a very focused approach or with a more exploratory approach, and both are going to yield useful results. And so essentially, when we click on Find Strategies, we're going to get this list of top matching strategies. And so we got 17, and they're ranked. They're ranked based on the CIFAR-ERIC mapping on the level of consensus among experts from the CIFAR-ERIC mapping study in how well suited a given strategy is to address a given barrier. So we've got across the top here, these are the barriers that we selected. And if I want to remind myself what one of them means, I can click on that question mark. And then we've got the barriers that are well addressed by a given strategy listed here. And the color coding goes from less well addressed being gray, and we can show them here if we want, then yellow, and then green. And if we wanted some details about, okay, what does that mean? Where is that coming from? We can click on that question mark that I just clicked on, and I'll show you again where it is. And then some details about what is the algorithm for ranking exactly. So here's the question mark if we wanted those details. Let's say I look through this list and I want more. I want more strategies that could match those barriers, even if it's going to be less strongly linked. It helps our team, for example, brainstorm or think through what might fit for us. So you could click on show more strategies here, and you're going to get more of these. And you can click here on show low matching barriers if you want to see exactly why those strategies are recommended for that particular combination of barriers. The other feature here, and this has come out of some of our early user testing, and we're hoping that we're going to get some feedback from you all as well as beta users. And actually, I'm going to pause my description because I see someone in Zoom has put their hands up. Would you like to unmute and share your question or comment?
Sure. I think that was me. I put it down because I realized you might explain it,
it's
later
okay.
on.
We can have a conversation. Yeah.
How does the ranking work? So for example,
Sure.
if I were to put multiple barriers, like some of these implementation strategies, I mean, as you've listed here, might address more than one barrier.
Absolutely.
So is like the top strategy one that addresses the greatest number of barriers, for example, that you listed, or is it instead like, I guess that's what I'm interested in.
Perfect. So it's a combination of three things primarily at this point. One is the strength of our confidence about the linkage between a given barrier and a given strategy, right? So it's that number, which is based on the CIFAR-ERIC mapping study. But as we take this to other frameworks, to even stakeholder-generated data, that could be anything you want it to, right? It could be based on stakeholder consensus, right? It could be based on strength of the evidence in the literature, right? So for CIFAR and ERIC, this number is based on the level of agreement between experts in that CIFAR-ERIC mapping study of identify and prepare champions is a strong strategy to address culture-related barriers. So one component of the ranking is these individual scores. Another component of the ranking is the number of barriers addressed and the cumulative scores among the barriers, right? So a strategy that addresses a number of barriers to a medium amount and a strategy that addresses a single barrier to a strong amount might both rank better than a strategy that addresses a couple of barriers to a medium or low amount. And then the third thing was the feature that I was just about to talk about. So this is perfect segue, is what if these barriers are not equal for you? You know this setting really well, and you've worked with your stakeholders and the implementers on the ground, and you know that these 7 barriers that right now in this cycle we're focusing on, there are really 2 critical ones among them. So you see this exclamation point here. If we clicked on it, it will re-rank to prioritize strategies that have to address one of the critical barriers. And all of that ranking logic that I just went through is described in detail if we click on that question mark next to the top matching strategies. So I'll go over it since the question came up. So a strategy is considered a top match if it addresses at least one high matching barrier, and high matching is based here for Seifer and Eric on the way it was defined in the Seifer-Eric mapping study, Waltz 2019. So it addresses at least one high matching barrier and at least one critical barrier. So those barriers that we've put that exclamation point on, if we've selected any. And then we're sorting according to these criteria. Needs to be a top match. So it addresses at least one high matching, right? So over 30%, and at least one critical. And then after that, if it is a top match, we're going to prioritize the ones that have more critical and more high matching barriers over ones that have fewer. And then we're going to take the one that has the highest score on its critical barrier. So barriers that are critical and that are high matching, we'll start with the highest score down, and then we'll also look at the cumulative score among the high matching barriers. So this sorting logic sort of algorithm has come out of a lot of testing and working with users. And then if you, as you work through this, have better suggestions or things that doesn't quite work when you work with your stakeholders, then definitely we want to hear from you. Yeah, go ahead.
Is this I'm so sorry. I feel like I am asking
No,
too many
this is
questions.
good. This is exactly why we're doing this. Yeah.
Is this in order? Like
Yeah.
For example, considered a top match as the first, or are they each weighted
Yes.
equally?
Yeah.
Or okay.
So it starts from the top.
Okay, thank you.
Yeah, you bet. And then if there are ties, they're broken according to these rules here. So first with the cumulative score, and then with the score of the highest matching, and so on.
Can you change, like,
yes.
Me as an individual user, could I change the strategy ranking? Like if I'm interested in strategies that address the greatest number of the barriers that I've listed.
Oh, can you change the ranking algorithm?
Yeah, or
right.
like, is there a way to sort, like, okay, well, this particular implementation strategy addresses, the most barriers of those I listed?
Sure. Right functionality isn't in place, but can you give me an example of a situation where that might matter?
Sure. Like if I only have enough funding, I mean, I do research, but if I'm working with a community organization that only has enough funding to implement one implementation strategy, and they're thinking, okay, well, this one might address the greatest number of barriers.
Oh, I see. Sure. So you want to prioritize ones that have a large number of barriers addressed.
Yeah, of the barriers, the community or organization previously listed.
Yeah. So right now you would do it by inspection, right? So you would scroll up and down, and you would quickly be able to see that the ones that address that criterion are the identify and prepare champions and the assess for readiness and identify barriers and facilitators. And because the ranking is really it's not going to produce like 50, right, or 40. It's going to produce a manageable number. Right now, this is the way you would do it. But we'll add your question to our frequently asked questions, and I'll go over that in a minute. And if that ends up being sufficient feedback, then we might consider adding it as a functionality where you would have essentially an option of sort by, right, which is what you're getting at essentially, right?
Yeah, and that's good to know that there's not going to be like 50 matching strategies.
No,
I guess I was envisioning if I had more barriers, maybe there would just be like this endless list of matching strategies,
Yeah. So if I change the barrier selection, right, and go here, and let's say for the sake of argument, we select all, which you would never be in a situation to do that. and we click on Find Strategy, even selecting every single barrier, we're still at 47 top matching strategies.
Okay, awesome. Thank you.
Yeah, so we worked through this to make it a useful decision support tool. Thanks. This was really good because it allowed us to get into some of the pragmatic questions. So what I'd like to do is go back to the presentation and go over an example so that we can get into the prep implementation version of this. So this is an example that's coming from the systematic review that ISCI has done. And let's say you're focusing on cisgender women, non-HIV clinical care, and you wanna figure out how to implement PrEP for them. So you've got these different determinants, and you've identified that they're related to these different CFIR constructs. So we've got access to knowledge and information. We've got available resources, addresses a number of these specific barriers, compatibility, culture, and relative priority. And so I'm gonna combine the next two things that I was gonna show you into one in the interest of time so that we can have even more discussion. So remember when I showed you this, I was showing you the general with no specific application selected. This is the screen that you're going to see as an EHE affiliated user. You're going to see this screen and it's going to tell you, look, welcome. These settings have already been set specifically for you. You don't need to make any changes. Of course, you can feel free to make changes you want, but these are specific for PrEP implementation barriers, specifically corresponding to CFIR. And so you're gonna go in here and you're gonna select the ones that are interesting to you. And because we've put in the data from the systematic review of PrEP implementation barriers that ISCI has conducted, we've got these examples. So if you're working on this with your stakeholders, with your on-the-ground implementers, and they tell you, I have no idea what intervention source means, here, looking at it together, or they could get a login and they could look at it themselves. Well, here are a couple of examples, specifically for PrEP implementation of what this barrier means. So I've already went ahead and pre-populated the ones from that example slide that I showed you. So we've got culture, compatibility, relative priority, available resources, and knowledge and beliefs about the intervention. And you can see that we've got 15 top matching barriers, and we've got them ranked. Okay. And so if we said, the one that is particularly critical is available resources, they're gonna get re-ranked as well. So as you can see here, what we've gained on top of what we had before is not only do we get the general CFIR barriers, we get these PrEP specific examples. And in fact, when I go back to this strategy, if I click on these, I'm still gonna get these PrEP specific examples. So as you're working with your teams, you get this list and you're going to say, okay, these are the ones that matter for these specific examples. As more results come out of other systematic reviews that ISCI and others are conducting, and there are these kinds of specific evidence-based examples for PrEP implementation for strategies, we'll be able to show those in here as details of these strategies. This is what this would look like, for example, for PrEP implementation. In the future also will be, I see the thumbs up, great. In the future, we'll also be able to have links here to, here's how you would do this specific strategy in another page. The other thing is ISCI is working on doing a similar systematic review, getting those kinds of barriers, not for PrEP implementation, but for implementation of HIV testing. And so this platform is very extendable, very scalable, where if rather than having the application be PrEP, it could be HIV testing. And we've done some work with other things like telehealth. So, so that is what I wanted to show you here. What you will have access to is the CIFAR and ERIC, as well as the CIFAR specific prep implementation barriers. And in the future, there'll be more coming from ISCI that will fold into this. Questions or comments about that piece? And then we'll go into how to log in.
I guess just in general, I mean, I do prep research, so the prep example is great for me. I think it's super useful. I can't wait until the implementation strategy examples are out.
Yes.
But do you all plan on also doing other topics, for example, linkage to care or adherence, other programmatic things related to ending the HIV epidemic?
Absolutely. So myself on the Agile team, I'm working with a number of other national networks on other topics, like, for example, the Cancer Cessation Consortium and things like that, and work on heart disease prevention. As far as the HIV work is concerned, I'm going to direct the question, perhaps Pablo or others on the ISCI team who are on the team might have some sense of what things might be looking like in the future for HIV specific barriers and strategy data that might be coming in.
Yeah, I just answered that question too in the chat. Yes, the goal will be to at some point be able to address all of the 4 pillars using the Agile tool as well as other tools in development. And hopefully those things will be forthcoming next year.
Great.
And I know you went over this in the beginning, and I'm so sorry if I'm monopolizing the questions.
No, please, this is great. We want this to be interactive. And the recording will be there for others to benefit from your great questions. Oh,
okay. Maybe I should have asked fewer then.
No,
I know you went over this in the beginning. You were talking about facilitators and barriers.
Sure.
I guess, is there a plan to also do this with the facilitators?
Sure.
If someone's taking like an asset-driven approach or something?
Absolutely, absolutely. Okay. And in my work, I take that approach. I start by working on facilitators and then the barriers. Right now, the Agile tool is a decision support tool that takes what is known in the field of implementation science and feeds it to users in a decision support format. It's taking what we know. And we don't know as much about the mapping from strategy to facilitator as we do about the mapping from strategy to barrier. And the simple reason is, let's say you selected 3 facilitators, 3 strengths that this site has of the 39 CIFAR constructs. The strategies would need to be things like, what strategies need to be used to amplify this facilitator, or better take advantage of it, right? Or maybe the facilitator is already being a strategy. So right now, what the field has done is focused on, there's a barrier, here's a way to overcome it. But as the field evolves in thinking about, here's a facilitator, what would a strategy do? Is it going to amplify it? Is it going to better promote it? Is it going to, are we going to skip the strategies related to that construct because it's already covered? You see what I mean? There's some open questions about that.
Yeah, definitely. And even if someone has a facilitator at their site, that doesn't necessarily mean they're using all of the implementation strategies.
That's right.
That could further amplify it. So yeah, it's really interesting to think about.
Yeah, and then you get into interesting situations where the same thing can be both a barrier and a facilitator.
Yeah, definitely.
Yeah. So as the field grows, as we learn more about barriers, as we learn more about strategies, as we learn more about facilitators, as we learn more about the interplay between all of them, we've developed the Agile platform in such a way that it can grow with the field. As I showed you, all of these are lists, are inputs into the platform rather than hard-coded. So if someone publishes publishes, and in fact, ISCI has the facilitators to prep implementation from their implementation, from the systematic review. We have that data. We just didn't put it in because the way the CIFAR-ERIC mapping study right now was based just on the barriers. So we do have examples of prep implementation facilitators, but what we don't have is what would you do with them strategies-wise, which can be part of the next few rounds of work.
Thank you.
Yeah, thanks. These are fantastic questions. So I'm going to use this as an opportunity. In fact, I'm going to stop sharing and share a couple of comments. I'm going to use this as an opportunity to share that what comes next is that the ISCI team is hoping that you all will be beta users for a number of months. And then as the next round of EHE, sorry, supplement RFAs comes out, we're gonna work with NIH to see if they would like to make that part of the RFA, that the use of the Agile tool that you could write it into your next grants. And then later in the year, ISCI will also be working on its own renewal of ISCI, and we'll be working on folding this into the next ISCI grant. So we can do a couple of things with the remaining time available. We can do more discussion of questions and comments. But I can also show you the registration login. Can I get a quick sort of thumbs up? People who have tried to log in, has anyone had difficulties with logging in? Maybe you can put a thumbs down or put something in the chat if you'd like me to go over the login.
I hadn't experienced any issues. Oh, sorry.
Yeah.
Oh, I was just going to say, I haven't had a problem logging in, but I gave up logging in because I wanted to pay attention to your presentation.
Yeah.
And I was going through the myriad of tabs and had to go back to my email. So I don't think I had a problem. I just gave up on it. I didn't fully go through with it.
Yeah, and this is part of the beta phase. We're piggybacking on a login process from another set of projects. It'll get even more streamlined in the next year, where right now you have to put in Agile HIV EHE 2022, and then someone sees that and approves your request. In the next year, it'll be automatically, if you put in that code, your request will automatically be approved by the system. So I'm gonna go ahead and say, what questions do you have? What comments or pieces of discussion? We can focus on that, and then if there aren't any, I will go over the login as a walkthrough for the recording. But what questions do you have that might be even more valuable?
Maybe just a clarifying point on when you're creating an account. When I
Yeah.
made one a couple of weeks ago, I think there was a comment that popped up not to use an EDU email
Sure.
address if preferred.
Yeah.
Is that like an actual
Sure.
barrier, I guess? Or
It's not. It's not.
Okay.
That's one of the holdovers from previous versions of this process that we're piggybacking on. But no, essentially any login request will be approved within 1 business day. Yeah. And in the next year, it'll be more automatic. The system will automatically approve it if you put in the code that we give you in the instructions. Yeah, good question. What other questions or comments or discussion points does anyone have about Agile overall or Agile for HIV, ending the HIV epidemic?
I actually had a conversation with ISCI recently as far as their existing utilization of Agile. And I think they were really just kind of building on who would want to use and understand the barriers and facilitators to prep. So I'm very curious. You said you're working with other organizations, and what are their intended usage of of Agile for their
Yeah.
respective grants? Does that make sense?
Great question. Yes. So ISCI is ground zero. It's the furthest along right now, and so we're in the process of launching this beta cycle where you all will tell us how you're using it. From earlier conversations, there are a number of ways that people are intending to use this. One is during and before an implementation, a research team or an implementation team or a collaboration between a research team and an implementation team, or even an on-site team, not implementation practitioners, like actual clinicians and clinical staff, might go in and plan prospectively and say, we're planning on implementing PrEP, but we think these 7 things will be an issue. Here are the kinds of things that we might want to try before we implement, as putting them into our implementation plan. So prior to implementation. And it can be any combination of users, right? It can be researchers, implementers, on-site people, or collaborations between them. You could do it in a meeting. You could do it in advance of a meeting. You could send a report from Agile by email and so on. During the implementation, we've been implementing for a month. These are the barriers we did encounter. We're going to remove the 2 that we did not encounter, for example. Here are the strategies that we're going to potentially use moving forward. And you can do this as many times as you want, right? Let's say your implementation phase is 6 months. You could do it on a weekly basis. You could do it on a monthly basis. You could do it at the 3-month mark, or you could do it ad hoc. When someone says, this is not working, you come in and you do it. And then third, after an implementation, you can use it as part of your evaluation. Why did things not work? Why did things work so well in these 3 sites and so poorly in these 4 sites? You can look at what barriers did the high-performing sites face, what strategies did they use, what barriers did the low-performing sites face, what strategies did they use, and any combination of those 3, so before, during, and after. We've also heard people talk about potential uses outside of a specific project setting. You could use it in planning your next grant, but you could also use it in training a cohort of scientists who are interested in implementation science to engage with these frameworks. With what does it mean when we talk about barriers? What does it mean when we talk about strategies? What does it mean when we talk about tailoring? You could use it as part of some folks have talked about wanting to use it as part of a K cohort, like a career development awards training program, and so on and so forth. A wide variety of potential uses. Does that help?
It does. In addition to that, actually, that's very helpful, because what I'm hearing now is what's very attractive about it is we can use this to help adapt and evaluate kind of evidence-based programs or evidence using, a way of kind of adapting and evaluating using it in like the D&I, and I'm trying to place it as far as the adaption, as far as evidence-based, and I'm not clearly articulating it, which means I need to think about it a little bit longer. But the second question that I have is, I know you said that, especially with like ISCI, it's based upon a literature review. I'm very curious, as you build your database of individuals who are putting in, barriers and facilitators for different groups, will you make what are your thoughts on making distinctions as far as saying these barriers and facilitators are based upon literature or scientific background, and these barriers and facilitators are based upon a community stakeholders, right?
Yes.
So I think that'd be really attractive, especially like if we're trying to say in our grants, like we're using kind of community engagement strategies through this because you're recording and you have the recording of community stakeholders. Does that make sense?
It makes a lot of sense, and I'm really grateful for my question askers today, because you're giving me great segues. So in fact, as part of the work that I've done, I've worked with a patient advisory board and a healthcare advisory board, and one of the versions of these inputs to Agile that we've done with our own work is we're working on creating a way to show these are these are inputs coming from the patient perspectives. These are inputs coming from the healthcare perspective, and that's just from stakeholders. So you can have a variety of sort of source information, whether it's from this kind of stakeholder, that kind of stakeholder, from a systematic review, from actual trial information, and so on and so forth. So yeah, that's part of the extensibility of the Agile platform, is to allow that kind of information to grow with it. So we are at time, but I am available to answer any additional questions that anyone has, and I'm leaving this acknowledgement slide here on for you all to see that this is really a village. Really grateful for the funding and the collaborations that have gone into this, and very looking forward to individual emails from you all if you would like to explore not only questions about how to use this within EHE, but if you have questions about, how could we extend this for this other thing or for this EHE specific thing, happy to have those conversations as well.